I would already, my previous speakers have alluded to this topic on measurement, and I'll be concentrating on the pitfalls. So we all know that FFR has a well-defined normal value of 1 in all arteries, all patients, well-defined threshold. It takes into account collateral flow as it has been shown, and it accounts for the effective perfusion territory, reproducible, not influenced by hemodynamic changes like blood pressure, heart rate, contractility, valid in almost all clinical conditions and lesion subsets, unsurpassed spatial resolution. But all this holds good only when we make an accurate measurement of the FFR. So the accuracy in measurement is the most important step. So the most important, already the steps have been alluded to. I only want to concentrate. The most important thing is first we should consider the patient history and the measurement context. The rest all have been alluded to already. The importance of nitrates has been stressed. All these topics have already been alluded to. And cross the stenosis and the wire should be placed at least vessel diameters beyond the lesion to make an accurate assessment. So this also has been told, the transducer higher, the PA will be lower, the transducer lower, the PA will be higher. And this is the first wrong step in measurement of an FFR or an NHPR. So you have the transducer higher, the PA will be low, and you can get a high FFR or an NHPR. Transducer lower, you can have a lower value of FFR or NHPR. So the other important thing is a reverse or a paradoxical gradient. This can happen because the patient is in a recumbent position, and you can have the aorta at a different level than the apex of the heart. Then loose connections. We all know the loose connections of the Tuhoy burst valve can cause a discrepancy in the values. Then the most important thing already been told is the needle inside. The needle has to be removed at equalization as well as measurement, because the space around the needle can cause a loss of the pressure and the PA will be low and you'll underestimate the stenosis severity. So this is the true RFR, and if you have the needle inside, this is the RFR. So guide catheter issues. So always you think whether can I use a guide, can I use a side hole guide, can I use a diagnostic, can I use a 5 French? You have to remember that these do not produce reliable pressure tracings, and there is always a friction for the wire movement whenever there is a diagnostic catheter inside. So, and you have a side hole catheter, it is recommended that you do not use a side hole catheter for measurement of FFR, because the coronary, the aortic pressure you measure is a combination of the aortic pressure and the proximal coronary pressure. This underestimates the FFR. And also you cannot administer intracoronary adenosine, which will go into the circulation rather than into the coronary artery. And you have small guide catheters, guide liners, contrast. The importance of flushing the contrast out before measurements has already been told, and otherwise you will have damping of the aortic pressure. You can see that there is no dicrotic notch, and you will have an underestimation of the FFR or the NHPR. So you have the guide catheter which is wedged into the coronary. This also has been told. It will lower the PA, and you will have a FFR or an NHPR which is higher. The stenosis severity will be underestimated. So you can see the loss of dicrotic notch in this aortic pressure tracing. So that is the important step. It's not only important to measure the pressure, but it is also important to inspect the curves. So you can see that we disengaged this is while damping in the middle of the picture. When we disengage the guide, you can see that the true FFR or NHPR is observed. So the most important thing is drift. You know that drift occurs during measurements. Only less than 5 millimeter mercury per hour is an acceptable drift. And what do you do when drift occurs? So the wire, after measurement, the wire is pulled back into the guiding catheter. The PDPA should be 1 and the curves should be superimposed. Only then you know that a drift has not occurred. If not, do not compromise, always normalize, repeat the procedure. So this also has been told, the inspection of the curves. If the distal curve is identical to the aortic, or if there is a maintenance of the aortic notch in the distal signal, it is drift. So you can see that a drift, these curves on pullback are not superimposing. So drift has occurred. And drift, as you can see, affects NHPR more because the range of values is less. And no signal drift during on pullback, the value is 1 at pullback. You know that you've made a good pressure recording. So this is very important because it will assure that you have done a true correct assessment. This via sensor, VIP has already been shown, and presence of any complete heart block due to administration of adenosine and has to be taken into consideration. The most important thing when we do an FFR is we do hyperemia. What are the pitfalls? Intracoronary adenosine, submaximal stimulus in about 10 to 15% of the patients, and you're interrupting the aortic pressure to administer the drug, and you have to calculate the gradient at not from the mean but from beat to beat, and so you have to see, because the intracoronary adenosine the effect wanes off so fast, so how you have to time your measurement. And supposing you have a large guide catheter or side holes, the drug is not administered into the coronary. And intravenous, preferable to use a central vein. If you're using peripheral vein, you have to see it is large bore access. You have to avoid kinking. You have to avoid Valsalva. Caffeine, you know, it impacts intravenous adenosine because it non-competitively inhibits the adenosine receptors. So your hyperemia is an important condition and it has to be fulfilled before your measurements. Supposing you get a non-ischemic FFR, you're saying it is a tight stenosis. You feel that you have measured right. You have to consider, as I said, the clinical context of the patient, which is very important. The small perfusion territory, little viable tissue, small vessels, collateral, severe microvascular disease can cause this non-ischemic FFR. Maybe there is another culprit lesion, diffuse disease, or a chest pain of non-cardiac origin. You always have to rule out technical explanations. That is an insufficient hyperemia. Guiding catheter, which is the most important thing before considering it non-ischemic. And you can have a false negative FFR if you're measuring in an ACS situation, severe LVH, or possibly it's an exercise-induced spasm. So this has already been shown, and the discordance has been told by Dr. Robert already. So I want to consider the procedural factors before you label, because 15 to 20% of the patients, there is a discordance between NHPR and FFR. And you have to consider the pressure, which is the most important things are the aortic pressure damping due to guiding catheter position, contrast in the guiding catheter, and no nitrates. Nitrates have to be given before making appropriate measurements. Apart from that, this already has been told in this I will show in a later slide. So again, if you have a normal FFR, abnormal NHPR, you have to consider the procedural factors, that is which I already told you, avoid pressure damping, and hyperemia. If you're making measurements even before the hyperemia has set in, your FFR value will not be correct. And if maybe you have an insufficient hyperemia due to an inadequate dose or an inadequate caffeine restriction. Apart from that, you already know the clinical setting of by Varsava et al., who have shown that in diffuse disease, there is a moderate gradient at rest and mild increase at hyperemia, whereas focal disease, LAD location, like in an LAD location, where the separation plays a more important role than friction, you can have an FFR which is positive and an IFR which is negative. This you have to consider only after you make a proper assessment of your technical and measurement factors. So I would like to conclude by saying that one accurate measurement is worth 1,000 expert opinions, and always we have to make accurate measurements before we interpret our results. Thank you.